inviting me to give a talk on this very successful meeting, which I've enjoyed and learned a lot so far from my colleagues. The role assigned to me is to talk about a few aspects about the left atrial appendage occlusion. I will start by touching on anatomy, talk a bit about the physiology and function of the left atrial appendage, and then we'll talk about the indications in this day and age of closure or isolation, and then we will have a few words about the issue of anticoagulation post-closure of this important structure. Right. Let's start by anatomical consideration. The left atrial appendage is a finger-like projection of the left atrium. It can go posteriorly and it can go anteriorly, but it is a wrap-round finger-like structure that is often referred to in the literature as a ear of the dog, which very much looks like it actually. Interestingly, it has a very thin wall, but it is very rich in prominent projections of the pectinate muscles that I'm sure we all had questioned from time to time once we're doing a transesophageal echocardiogram. Is it a pectinate muscle or is it a thrombus? And we have to resolve to things like injective contrast sometimes to help us answering this question. It has an oval orifice, but it sometimes comes as a triangular or a raindrop. It leads to a neck, and the neck leads to a body, and from the body there are many lobes, usually two, but it can be in multiplicity or less than one. Now, anatomically, there are very important relations that has to be known by heart for interventional cardiologists who are interrogating the left atrial appendage. The ligament of Marshall, or the Comedine ridge, is by far the most well-known. We also have the left upper pulmonary vein in close proximity to the ligament of Marshall. We have the main pulmonary artery, especially in close proximity to the tip of the left atrial appendage. And we have the left circumflex artery, great cardiac vein, and the left phrenic nerve. Any of these structures could be severed or affected during any procedure that is interrogating the left atrial appendage. This is how they look like. You have, this is a great cardiac vein, and near to it you have the circumflex artery. This is a ligament of Marshall, which is actually the remnant of the left superior vena cava, and you have the phrenic nerve coming longitudinally. This is how the neck looks like from the orifice into the body with different lobes. Now, anatomically, we can have different anomalies. By far the easiest to assume is that there might be a congenital absence of the appendage, although it's an extremely rare thing, but it theoretically could happen. If you have a pericardial issues like pericardial absence or absence of a pericardium on that particular place, there will be a herniation of the appendage on that particular spot. One of the well-known developmental abnormalities is dysplasia of the pectinate muscles causing left atrial appendage aneurysm. And I'll show you a transesophageal echocardiogram on a patient whom I've seen 4 years back. She actually came, she was 22 years old, and she came post-delivery with heart failure, atrial fibrillation, and she was diagnosed at her local hospital as purpura cardiomyopathy, and she was referred for further management. Transthoracic echocardiogram showed normal left ventricle, but there was a huge mass attached, which is vacant or a hollow-like structure attached to the left atrium, and we thought it might be a left atrium appendage. So we did a transesophageal echocardiogram. As you can see, there is a left atrial appendage aneurysm. I'm not sure why this slow one is not working. So this is lots of stagnation of blood in this aneurysmal left atrial appendage, and the patient was operated on and the appendage aneurysm was ligated, and the second day post-operatively the patient regained her normal sinus rhythm and discharge. So this is actually one of the 17 cases which are reported worldwide of the presence of left atrial appendage aneurysm due to the dysplasia of the pectinate muscles. Now, the other very relevant anatomic variations or problems concerning the left atrial appendage, it is relevant to the occlusion, is that it has different structures depending on the number of lobes. By far the commonest is the chicken wing appearance. So half of the audience in this room, hopefully myself included, is we have a chicken wing appearance because it is the least related to the incidence of thrombosis. We have the cactus, and we have the windsock, and they have the cauliflower. They all attract their names from this is how they look like actually. And this illustrations of how they look like in transesophageal echocardiogram and how they actually look like when you inject the left atrial appendage itself. Starting on this side, this is the chicken wing, this is a cactus, this is a windsock, and this is a cauliflower, as the name indicates. I'm not quite sure, I mean, we do transesophageal echo from time to time, I mean, on daily basis, day in and day out. I'm not quite sure how easy is it for each one of us to actually clarify on transesophageal echocardiogram which of the 4 types are there. Maybe without the use of 3-dimensional echo, it might be difficult. But as you can see, the variations may be not quite great. This oldish slide shows the incidence of thrombosis and the incidence of a stroke risk comparing or as per the type, anatomical type you have. So the least thrombogenic is the chicken wing, thanks God is the 50%, and the most thrombogenic is a cauliflower, as you might anticipate. Now, let's move to function. It's not a dead organ by all means. The left atrial appendage is an endocrine organ. It secretes 30% of the left atrial natriuretic peptide. Now, how much atrial natriuretic peptide contribute to the natriuretic peptides in the body in human physiology might not be that much relevant, but at least in animal studies, it does produce a good amount of natriuresis, so it's important in heart failure. It is a reservoir for what is called as the cardiac stem cells, so that might be something to look for in the future direction of stem cell treatment for heart failure and intractable scar muscles following infarcts. Now, the left atrial appendage is not a dead space. It is a reservoir for blood, but it does contract. And this contractility that we all measure in terms of velocities, the nice 4 to and fro waves on velocity interrogation of the left atrial appendage, we see that very much clear when we do the transesophageal echocardiogram. Even in the absence of atrial fibrillation, i.e. in the presence of high ventricular end-diastolic pressure that we see in cardiomyopathies, we can see that the velocity decreases, and this is probably by far the commonest reason why patients in sinus rhythm can still develop left atrial thrombi. Last but not the least, the left atrial appendage itself is a source of atrial arrhythmia, which can be quite stubborn to treat and interrogate in patients. Why we are interested in this organ? Because of these 2 statements. 90% of left atrial thrombi in the presence of AF form in the left atrial appendage. And 40% of thrombi in the presence of sinus rhythm still form in this place. So it's a quite nasty place to have, unfortunately. It harbors most of the catastrophes. This is a transesophageal echocardiogram on a patient whom we've seen last week. He actually is a 52-year-old man. He came with episode of shortness of breath on exertion. He has never complained before with nothing to suggest anything in particular. He came with shortness of breath, and his BNP was high, and he had wet lungs, so he was admitted with a new onset heart failure. He had atrial fibrillation at that time, but he went back to sinus rhythm on his own. On transthoracic echocardiogram, there was the suggestion or the diagnosis, which we'll show in the next echocardiogram, but there was a suggestion of a thrombus in the left atrial appendage, and that highlights the importance of actually seeing this structure even in transthoracic. I mean, we know that in many of the very young population in whom mitral valvuloplasty can be done, you don't need to proceed for transesophageal echocardiogram to see if there is or isn't any left atrial thrombus. This is the reason why this patient had his left atrial thrombus, left atrial appendage, large thrombus. It's actually a very tight mitral stenosis, and he had a severe aortic regurgitation. And the patient, interestingly, was quite asymptomatic, and he is 52 years old, and he presented with heart failure for the first time, actually. Now, this is our very glorious CHAS-VAS score that we all know by heart, and this is the reason why we indulge into the next step of LA appendage interrogation. The first thing we do in these patients, if they have the high score, if they have atrial fibrillation, non-valvular atrial fibrillation, the first step is to anticoagulate. But quite a number of patients we cannot anticoagulate for life. For so many reasons, the most, by far the commonest cause is they cannot tolerate long-term anticoagulation. However, before we move to selecting patients for left atrial appendage occlusion, there are a few caveats that we have to know. This LA appendage occlusion, once we insert into the left atrium, is a foreign body. So it's a nidus for thrombus formation itself. So by definition, the first few weeks of following implantation, we have to anticoagulate the patient, which is a paradox. You are using anticoagulation in a patient whom you are putting a device to avoid anticoagulation. There is a small but a significant incidence of a device-related thrombus formation, as we're going to see. And remember, when we talk about stroke, we talk about cardiovascular risk. Yes, 90% of the patients' thrombi are located in the left atrial appendage, but we would not forget that the aortic arch, the valves, and the carotids are by no means are risk factors for thrombus formation and embolization. There are some morphological variations, as we've seen, the windsock, the cauliflower, the cactus. Some of them, they are deemed quite difficult to actually have or to harbor the device. So this is a current status for the closure. So to put an LA appendage occlusion, it may be considered for stroke prevention in patients with atrial fibrillation and contraindication for long-term anticoagulant treatment, and this is class 2B. So you can see the problems of really selecting the patient, putting into consideration all the problems, the pros and cons for inserting this device, because once it's there, it comes with all the problems. Now, the FDA has approved the Watchman device for routine for the LA appendage occlusion, but it has to come with a routine anticoagulation, be it with warfarin or a NOAC for 6 weeks, followed by dual antiplatelets for 6 months, and then allow for 325 milligram of aspirin for the rest of life. This is the recommendation so far. Now, in the two major trials, the PROTECT and the PREVAIL, there was mini group analysis using TOE. I wouldn't say TEE, I'm used to saying TOE, not TEE. TOE was performed on 6 weeks, 6 months, and 1 year to interrogate the possibility of a device thrombus formation. Now, the findings were not very pleasant. 3.7% had device-related thrombosis. The majority were picked up at 6 and 12 months. That's immediately after cessation of anticoagulation. So those who are more amenable to have that are those with higher CHAS-VAS score, those with bigger LAs, and those with lower left atrial appendage velocities. So suggested solutions, maybe anticoagulate for 6 months, which is interesting. This is, we are defying the very reason why we are deploying the device. Or maybe anticoagulate for 6 weeks 6 months following that with low-dose NOACs. Not to forget there are other options in the horizon, which is surgical isolation, the commonest being the lariat, which does not need anticoagulation. So there is a lot of work in the pipeline to suggest for that. And thank you.
So it's my pleasure to introduce Dr. Sami Ghazal. Dr. Sami Ghazal is an assistant professor and consultant cardiologist at Almana University in Dammam, Saudi Arabia. Dr. Sami Ghazal will be speaking about the theory of the Atrium Appendage program.
Assalamu alaikum again. So the talk is about TE for the left atrial appendage closure.